Hello everyone, in this video we are going to discuss about pulmonary hypertension. So whenever there is an increase in the blood pressure in the lungs, it is pulmonary hypertension in simple words. So the normal blood pressure is 10 to 14. If it is more than 25 millimeters of mercury, then it is pulmonary hypertension. So it is of two types, primary and secondary type. Primary type is idiopathic or heritable type. It is because of BMPR2 mutation. BMPR2 stands for bone morphogenic protein receptor type 2. It normally inhibits the smooth muscle cell growth, but because of this mutation this is inhibited, so there will be over proliferation of the smooth muscles. The trigger for this can be infections or any drugs like appetite suppressants and ion channel diseases. So these conditions will lead to PR3 mutation, leading to increase in the smooth muscle cell growth because of the inhibitory effect is lost, so there will be increase in the proliferation. So overall there will be increase in the endothelial 1 which is a vasoconstrictor. There is decrease in the nitric oxide, so decrease in vasodilation. Decrease in the prostacyclin leads to decrease in the vasodilation and decrease in the platelet inhibition. So there will be increase in the platelet aggregation leading to thrombosis and vasoconstriction effects. So there will be overall vascular remodeling. Because of this vascular remodeling, there will be smooth muscle hypertrophy leading to increase in the pulmonary vascular resistance. So this increases the pulmonary artery pressure and causes right ventricular hypertrophy leading to cor pulmonale and right heart failure. And coming to the secondary type, it is caused due to secondary causes like chronic hypoxia leading to pulmonary vasoconstriction, volume overload causing stress on the endothelium, and recurrent pulmonary emboli which blocks the blood vessels and increases the resistance and increases the inflammation, vascular injuries which causes increase in the fibrosis, proliferation and thrombosis, portal hypertension which increases the volume and toxins effects on the pulmonary vessels, drugs like appetite suppressants which induce similar vascular injury and endothelial dysfunction. So coming to the differences, first, primary is inherited or idiopathic, secondary is because of any underlying cause. The patients in primary will be young adult females, and secondary any age and depends on the underlying disease. Causes BMPR2 mutation, and second the trigger will be infection, drugs and ion channel defects. And secondary hypertension, it will be hypoxia, recurrent emboli, drugs and diseases like connective tissue disorders, HIV, schistosomiasis. So pathogenesis we already saw, there is mutation. Because of this mutation there is failure to inhibit the smooth muscle proliferation leading to endothelium decrease in the leading to increase in the endothelium, decrease in the prostacyclins and decrease in the nitric oxide. This leads to vasoconstriction and thrombosis and fibrosis effect leading to smooth muscle proliferation and medial hypertrophy of the pulmonary arteries, and intimal fibrosis and plexiform lesions are seen in the late stages. So medial hypertrophy and intimal fibrosis are main things. And clinical findings will be dyspnea on exertion, cyanosis, right ventricular hypertrophy which progresses to cor pulmonale and right heart failure. Next complications are right heart failure, and it is associated with BMPR2 mutation. The treatment will be, we will give vasodilators because there will be vasoconstriction, prostacyclin analogs because there is decrease in the prostacyclin, and we will do endothelium receptor blockers because there is increase in the endothelium, that is PDE5 inhibitors, and lung transplantation in severe cases. Coming to the secondary, it is caused due to secondary causes like hypoxia, recurrent emboli and all. The pathogenesis will be chronic hypoxia leading to vasoconstriction, and similarly there will be medial hypertrophy and volume overload and shear stress on endothelium, and emboli causes vasoconstriction, and autoimmune disorders itself cause vascular injury and fibrosis. So there will be medial hypertrophy, intimal thickening and thrombi. Clinical features are same as primary, but there will be features of underlying causes like COPD signs. We will see joint pain in the connective tissue disorders. Next is complications, same but depends on the primary cause. And associated syndromes are CREST syndrome is the commonest association associated with HIV, liver disease like portal hypertension, schistosomiasis. We have to treat the underlying cause, and vasodilators if indicated can be given. So primary is inheritable or idiopathic, secondary is due to secondary causes. In primary, BMPR2 mutation, the main thing is there is will be increase in the proliferation because of loss of inhibition of the smooth muscle cell growth.